Good afternoon, everybody. Dr. Vasquez here, and today we are going to talk about the neurosteroid pregnenolone. Now, I already reviewed in my book, Inflammation Mastery, the section where I talk about pregnenolone, and I wrote that, of course, over the course of many years because I have personal and clinical experience with pregnenolone now for about 25 years. Off and on for 25 years, let's say. So today I reread that section on pregnenolone from my book. I think it's in chapter 4, somewhere around page 700. And all of that information, as far as I can tell, is still accurate. So I don't have any need to change that. But I do want to look at a few new research studies just to see if anything's new. So if you have the book, hopefully you have the book, you can look at that section again in chapter 4. Let me see if I can give you the exact page number, if I can pull my screen up here. And you can look at that. Nothing changes there. I don't have any corrections to make. At this point, I don't have any major additions to make either. But we can talk about it and we can add a few details. So I'm referencing pages 702 to 703. So let's look at that information, more or less, and put it in context with a new article, a relatively newer article. Actually, it's 10 years old. But this is from Psychopharmacology 2014, Proof of Concept Randomized Controlled Trial of Pregnenolone in the Treatment of Schizophrenia. So I have a lot of interest in brain health, but I have essentially zero interest in schizophrenia. But we're still going to look at this study as it gives us data about the safety and tolerability of pregnenolone. So let me draw this out very quickly here. Kind of a clinically relevant diagram, let's say. I'll just draw it out spontaneously, just so you know what we're talking about in terms of what is pregnenolone. Some of you, I'm sure, are quite familiar with it. Some of you have probably never heard this word before. So let's talk about pregnenolone. I'm going to give you the biochemistry of pregnenolone. Now, I'm giving you the clinical version of the pharmacology of pregnenolone. And that's the beautiful thing about being a clinician, is that we basically get to make reality either as complex or as simple as we want, because we can always say as clinicians that we're just being practical. So you're going to see that play out right now. So the importance of pregnenolone, let's see, how do I want to say that? The importance of it, is obviously rooted in its pharmacology. So let's start with its pharmacology. So pregnenolone is kind of it's commonly thought of, or at least it was thought of, as being kind of an intermediate. But with time and experience and research, such as the study that we're going to look at today, which I've already read and I've already highlighted it, so I'll just go through it real quick. With the research that we've had available, actually now for about 70 years, we can't really continue to look at pregnenolone simply as an intermediate. I think we have to respect the fact that it has its own functions. So let's talk about the biochemistry of this real quick. And again, this is kind of the clinical pharmacology of it, which means it's mostly accurate, it's not completely perfect, but it's sufficient for clinical purposes. So typically we have thought of the precursor to pregnenolone being, of course, cholesterol. Body takes cholesterol, turns it into pregnenolone. And then from there, I'm trying to think of the way that I used to draw this out for patients. I haven't even thought about this topic probably in 15 years. So I'm going to have to reach a little bit. But I think the way that we've typically thought of it is that we start with cholesterol, then we go to pregnenolone. And then, of course, we get some other metabolites from pregnenolone. I'll talk about those in just a moment. So let me just say here, metabolites. Such as allopregnenolone and pregnenolone sulfate. talk about those in more detail in just a moment. But again, the general picture that we typically have painted has been cholesterol to pregnenolone, and then pregnenolone to cortisol, or to other mostly adrenal hormones like DHEA. And then we could go to testosterone and convert that into estrogens such as estradiol. That's kind of how we've thought about it. Like I said before, I personally started using pregnenolone, and I haven't used it, every day forever. I've gone entire years without taking it. But I did start taking it. I'll tell you why. I started taking it back in around 1997. And the reason is because I had adrenal failure. I had adrenal insufficiency. Now, if you'll pardon my Generation X vernacular, let me just state this very clearly, that I'm not talking about mild bullshit adrenal insufficiency. I'm talking about the real deal. I had real adrenal insufficiency. The test for real adrenal insufficiency is the ACTH challenge test. That is has been traditionally the gold laboratory standard for adrenal insufficiency. And I did an ACTH challenge test around 1997, and it was flat. I did that when I was living in Seattle at the time. I had graduated from chiropractic college. I was in naturopathic school, and that's when my health just went to hell, basically. So again, when I talk about my experience with real adrenal insufficiency, I'm not playing around. I'm talking about ACTH confirmed adrenal insufficiency. So around that time, in addition to doing other things, I started taking pregnenolone, and I had good results with it. So I continued taking it for many years. And then when we lived in Europe, obviously things are harder to get in Europe compared to the United States. In the United States, you can get anything basically you want. But in Europe and in other countries outside of Europe, getting supplements is much more difficult. So while we lived in Europe, I kind of ignored pregnenolone for a while. I didn't really feel like I needed it. I had a much more relaxed lifestyle. I wasn't hammering research and going to medical school and, working multiple jobs and things like that. So I didn't really feel like I needed it. And so I kind of forgot about it. And so recently I started thinking about it again, and I started to kind of revisit the research on it. And so that's why we're having this conversation right now. So again, this is kind of the clinical pharmacology of how we can reasonably think about pregnenolone. Starting again with cholesterol, converting it into pregnenolone. We get some direct pregnenolone metabolites, such as allopregnenolone and pregnenolone sulfate. I'll talk about those in just a moment. We can kind of think of pregnenolone as then getting converted into cortisol, maybe then DHEA, and then maybe testosterone, and then maybe estrogens. So, if you're dealing with a patient who's panhypopit, for example, or menopausal, or andropausal, and you want to use pregnenolone, you could use it. You could see what benefits you get. You could measure their downstream hormones like DHEA, testosterone, estradiol, see if you notice any changes there. Generally, any changes there would be very mild, if at all. However, we do have the clinical experience of encountering what you might call in the research literature as outliers. So every once in a while, as I recall from clinical experience, both my own and, for example, like within the office where I worked, every once in a while we would see things that we weren't expecting. So I do remember one case, and this was, back when I was practicing in Houston, Texas, and I do remember one of us in the office, I don't think this was my patient, But I do remember we collectively within the group office, we had a a female patient who was menopausal, or at least she thought she was menopausal. And as I recall, a little bit of pregnenolone and a little bit of DHEA, which would have been, physiologic dose for women is about 5 milligrams, 5 to 10 milligrams. And she started actually menstruating again, even though she kind of presented in a postmenopausal state. So anyway, those are things to think about. Probably that effect that I just mentioned, going from postmenopausal to then, perimenopausal again. We might think that was mediated. Maybe it was mediated by some other treatment, but of the two, we would probably attribute that to DHEA more so than pregnenolone. But as I recall, the two hormonal treatments were pregnenolone and DHEA. So what I'm going to do right now is kind of walk through this study, which I just read recently. Again, I have a lot of interest in brain health, and so that's what kind of has me on this track, looking at pregnenolone again. I don't really care anything about schizophrenia, even though I'm sure some of you care about it. But let's look at this study. Mostly what I'm looking at in this study are signals around safety or any adverse effects, and of course any benefit that they have derived. But again, in terms of like getting into the nuts and bolts of schizophrenia, in the same way that I would look at nuts and bolts with, psoriasis or rheumatoid arthritis or something like that, it's just not my specialty. So I've got the study right here. We're going to take a look at it, and I'll just kind of read through it and highlight whatever I think might be worth highlighting, even though, as you can tell from the screen image, I've already done my highlighting. So let's just talk about pregnenolone and why we might use it either in application to schizophrenia or taking this data and then applying that outside of schizophrenia. So the one thing I do want to say before I get into this, and I did make a note of this somewhere in my highlights and comments in the article, was to be sure that when we talk about therapeutics, we always have to keep in mind that, the guiding light of therapeutic intervention is risk-benefit ratios. So, for example, when we talk about the use of pregnenolone in the treatment of patients who have schizophrenia, that doesn't mean that we can take the same therapeutic and then apply it to ourselves or a friend of ours or a patient who has another condition. So, research and interventions are always context specific and context limited. In this case, we're talking about medicated schizophrenia patients. Half of them were taking 2 drugs. So this is not the same in terms of what we call a therapeutic threshold. This is not the same as you would find maybe in a routine outpatient clinic where you're just treating, a little bit of inflammation or a little bit of anhedonia or a little bit of fatigue or depression or something like that. Or like a clinical empiric diagnosis of adrenal insufficiency. When you're dealing with, a more hardcore, severe level of disease, you have more therapeutic freedom, so to speak, than you do if you're treating something that's rather mild, because, like I said before, we justify our interventions based on what we call a risk-benefit ratio. So if the potential benefit is greater, then we can afford to take more risk therapeutically. And that, specific to this intervention, would mean higher doses. So let's talk about dosages. As I said in the book, and because that was my clinical experience and it's still correct, the doses that I've most commonly used with pregnenolone are 10 milligrams, 30 milligrams, maybe up to 50 milligrams. And my clinical use of pregnenolone and my personal use of pregnenolone differs from the research literature in that, for whatever reason, I've been successful in the use of pregnenolone using much lower doses. And, the most obvious reason or explanation for that would be that I use, combination interventions and synergistic formulas and things like that. So I would expect, and I plan my interventions to achieve better results even with lower doses, because I'm doing other things as well. Whether it's specifically, obviously other nutrients, but also in this case I would commonly use other botanical medicines to have a synergistic effect with the pregnenolone. So, of course, most clinical trials, like the one that we're looking at here, these are monotherapy. These are mono-intervention studies where they're just looking at one agent. So typically they have to use higher doses to get any benefit whatsoever. In clinical practice, what distinguishes a good clinician in many ways is the fact that they can avoid super high doses of interventions because they are using synergistic combinations. So again, in my personal experience and clinical experience using pregnenolone, I'm usually looking at 10 to 50 milligrams, maybe 60 milligrams. In a lot of the clinical research studies, the ones that have been published, they're using up to 500 milligrams. So again, that's why I started to say just a moment ago that you always have to put your intervention in context, for example, in this case with what's being studied. So they started their patients here with 100 milligrams, and then I think they went to 200, and then to 500 milligrams. I would never, I personally, most likely, would absolutely never use 500 milligrams. If I personally took 500 milligrams, I probably wouldn't sleep for 5 days. Just because I know what my therapeutic range is for me personally. And I'll tell you what that is, and I'll tell you, and the reason I'm telling you this is so that you know how to implement this clinically if you've never done that before. So, because as I recall back in 1997 when I first started using pregnenolone, when I had adrenal insufficiency, I'm pretty sure that I started at a dose that was too high for me, and I think that dose was 100 milligrams. And maybe that's just what was available at the time. That's how I remember it. Because I had another patient around that time. I'm sorry, let me just think about that for a moment. So I know that I started this for myself around 1997. But I clearly remember another patient that I had. But if he was a patient, then that had to be around 2000, because that's when I started practicing. So I couldn't, here's where the story kind of boils down. I personally could never tolerate taking 100 milligrams of pregnenolone. But I had a patient, a little bit older than I was, also a man, who tolerated 100 milligrams with no problem whatsoever. So the 2 points that I want to make are that people vary in their ability to tolerate pregnenolone, and I would encourage you to not start too high. I would encourage you to start like 10 or 30 milligrams, depending on the size of the capsules or the tablets that you have. Usually 10 milligrams or 30 milligrams is a pretty standard dose, and then you can always work your way up. This isn't something, in my experience, where you have to wait days and weeks to find out if it's working. You can usually feel it within hours. So, start, if you're self-treating, so to speak, then you assume the risk of what you're doing. If you're treating a patient, then you have to obviously be a little more conservative, if not a little bit slow, because you're dealing with somebody else's health and you have to, exercise an abundance of caution. So, especially if you're dealing with somebody who has other complications, if they're on antidepressive drugs, if they've had a history of seizures, for example, you would want to be really careful and start at a much lower dose. So a reasonable dose would be to start at 10 milligrams for an adult. 10 milligrams for a couple days, and then you could go to 20 and 30 and bump your way up by 10s in that way. Again, I would never start somebody at 100 like they did in this study, and I would further never go as high as 500. For me, that's just astronomically high. So let's look at what they did in this study, and let's look at why they did it. So let me pull this up a little closer to my face, and I'll take my glasses off so I can just read it and get through this data pretty quickly. The first, as you would expect, the first introductory paragraph provides a good summary, so I'm going to read part of that right here. Pregnenolone is neuroprotective. Let me underline while I go. Pregnenolone is neuroprotective and enhances learning, memory, myelination, and microtubule polymerization. Treatment with pregnenolone elevates allopregnenolone, which is a metabolite or derivative that enhances GABA, and pregnenolone sulfate, which functions more in the modulation of the NMDA receptors. So that's actually pretty beautiful. So with one intervention, we get an enhancement of GABA, which has a neuroprotective and kind of a calming effect. And then on the other hand, we're kind of modulating, which is kind of a non-specific word, I realize, but we're kind of improving the function, let's say improving the function of the NMDA receptors. And that's awesome. So you're enhancing relaxation, but also enhancing a little bit of stimulation and learning, and of course that has good clinical benefit. Pregnenolone could thus potentially mitigate GABA dysregulation and or NMDA receptor hypofunction in schizophrenia via metabolism to other neurosteroids. And like I said, it goes downstream from there. So, this again is a randomized placebo-controlled study that's modern. A lot of the studies, for example, that I cited in the book were published back 70 years ago, 1950s and things like that, in the treatment of rheumatoid arthritis specifically. In this case, they had 120 patients treated for 8 weeks, and what they found were greater improvements in functional capacity. So that's basically what this study boils down to, and that's obviously very important. They found, some mild improvements in other area, but the most important take-home message from the benefit side, let's say, of this research is that they showed functional improvement. Pregnenolone was also superior to placebo in the communication subscale. And what I'm looking for here, because I'm going to take this data and apply it to other autoimmune and inflammatory conditions, what I'm interested in is, was it safe? And as they state here and several times throughout the article, pregnenolone was very well tolerated. Conclusions: pregnenolone improved functional capacity in participants with schizophrenia, but did not improve cognitive symptoms over an 8-week treatment period. The other thing I wanted to point out, again, talking about therapeutic contextualization, you're talking about diagnosed moderate to severe patients here. So you've got more leeway in terms of risk-benefit assumption and the risk you can take with intervention. The other aspect of context in this particular study, even though a lot of the lead authors, for example, are based in the United States, is that the patient population was actually, I believe, in Singapore. So that's important because you could expect genetic variations that could change the ratios of metabolites and the downstream conversion of pregnenolone based on the patient population. So again, does this apply to most humans? Yeah, it probably does. But given the fact that they were treating an Asian population, and the Asian population has been shown to have distinct metabolic patterns in terms of their detoxification and so-called drug metabolizing enzymes, that would prevent anyone from saying that this applies globally per se, because this isn't a multi-site international study. This is a study in a group of 120. That's pretty good, actually. 120 subjects or 120 patients, but they are racially defined and racially confined. This isn't a multi-site international study. So let's move on and talk about the details of this study. They talk about pregnenolone. It has a lot of benefits for the brain, at least in animal studies and in tissue cultures. They talk about pregnenolone sulfate, which I already said seems to be more active at the NMDA receptor. Allopregnenolone, more active at the GABA receptor. You can see my note here. I wanted to talk about risk-benefit in diseases versus symptoms. So again, schizophrenia is a mental disease. The risk-benefit ratio is different when treating a more severe disease than it is if we're treating someone who's just presenting symptomatically with a little bit of depression or fatigue or something like that. Let's see. So I made a few notes there. Those are just for me to include in the book, but I won't go through those right now. It's not really important for conversation here. On this page, they talk about some of the doses that have been used in other studies, and you can see those. Maybe I'll try to circle them or highlight them. 100 milligrams, 500 milligrams for 8 weeks. 100 milligrams, 500 milligrams for 8 weeks. That's obviously what they duplicated here. Again, for me, those are high doses. You can see at the top of this page, 30 milligrams, I'd be comfortable with that. 200 milligrams is a lot in my office. 50 milligrams is okay. Another study that used 500 milligrams. 30 milligrams, that's in my ballpark. And 500 milligrams is out of my ballpark. I would not use that much. So let's move on. See what else we want to say. Oh, yeah, this is important. I mean, this is true for a lot of different interventions, but basically we try to avoid using hormonal interventions in women who are pregnant or breastfeeding or have the potential to become pregnant. And you can see that I put a star by that note. So here you can see they used pregnenolone, 100 milligrams per tablet. They started with, I said previously they went from 100 to 200, but they went from 100 to 300 and then to 500. So, yeah, more power to them. I mean, that's pretty aggressive. I would not use that much. In any situation. So, for example, I would just do something else. If I were treating a patient with rheumatoid arthritis or psoriasis or MS, well, MS is different. But let's say rheumatic disease, some type of inflammatory arthritis. I might go to 100. I'd probably stop at 50, but let's say I go to 100, but I would be doing other things. By the time I would get to 100, they would probably be on, some therapeutic dose of other hormones. DHEA, maybe androgens, like testosterone specifically, obviously. Maybe an aromatase inhibitor. And obviously I would be doing other things for the microbiome, mitochondrial function, fatty acids, etc. So I have a hard time thinking about my own clinical practice going above 100 milligrams. I just don't think it would happen. I think I would do other things. But again, here they went to 500. That's a lot. As I mentioned before, this patient population is from Singapore, so you have to consider the genetic variation of that population. Asians, differentiated from, Europeans and North American Caucasians, definitely have differences in their so-called drug metabolism pathways. So you have to take that into consideration before you just say, hey, let's apply this to everybody, because you really can't do that. They had a good completion rate of 85%. And like I said before, the signal that I'm most interested in, the two signals, are safety and efficacy. They got a little bit of efficacy. None of us would have expected a lot. But they did show perfect safety, and I'm mostly interested in that. It seems like the female patients responded a little better than did the males. Adverse events in the pregnenolone group were similar to the placebo group. No participants in either group reported adverse events of severe intensity. Conclusions of this study. Main findings include the following. Pregnenolone significantly improved functional capacity in patients with schizophrenia. I mean, that's pretty beautiful. You have to also think about this treatment previously shown to be safe, and again here shown to be safe. You're talking about a few bucks, you're talking about a few dollars per month here. So if you can get functional improvement along with some theoretical benefits like neuroprotection in a group of medicated schizophrenic patients, that's worth going for. So for example, if you're a psychiatrist or within that range, if you're treating, let's say you have a clinical practice specializing in mental illness or psychiatry, then now you have something that you can actually work with. This is a reasonable intervention with no documented adverse effects and no anticipated adverse effects. So like I said before, theoretically, we go from cholesterol to pregnenolone to some other steroid hormones. Some of those steroid hormones, namely estradiol, have obvious cancer-promoting effects, not benefits, but they have obvious cancer-promoting effects downstream. Most of these studies, like I already said, were only for 8 weeks. So do we have 8 years of follow-up? Do we have 16 or 20 years of follow-up showing either more or less risk for colon cancer, prostate cancer, breast cancer? Do we have that data? Not if the study's only 8 weeks long. No, of course we don't. So you have to keep that in mind too. That, the farther outside you get from a controlled limited study, again, 2 months, if you start talking about using this for 2 years, 8 years, 16 years, 20 years, you could encounter adverse effects that, of course, could never be detected in a short-term limited study like this. Again, patients randomized to pregnenolone demonstrated significant improvements in functional capacity, clinically relevant to overall functional outcome, well tolerated, no serious adverse events, and then they go back and repeat themselves about mechanisms, which I already talked about. Modulation of GABA receptors and NMDA receptors, fine, we'll take it. A lot of other studies have already shown neuroprotective benefits. Good. Let's go for it. And that's the conclusion of the study. Significantly improved functional capacity compared to placebo. Did not improve cognitive symptoms. So they got some benefit, plenty of safety, low cost, and that's a worthwhile intervention. So again, when we're making clinical decisions, we have to look at the context. Within that context, we look at risk-benefit ratios. Did this provide a good risk-benefit ratio in the clinical model that was used here? Did it provide modest, in this case it did provide modest benefit with very low risk? Is that worth doing? Absolutely. What's the cost? So what if it provided a little bit of benefit with a lot of safety, no adverse effects, but it cost $200 a month. Is that worth doing? At that point, you'd have to say, maybe not. Maybe we could do something else with that money. But again, when we're talking about an intervention that maybe, especially at wholesale, maybe costs, $20 or $30 a month, that's worth trying. So, again, the way that you could implement this, if you are a clinician specializing in psychiatry, start at a low dose, work your way up, and then see how your patient responds. If after, let's say, 2 or 3 months, you've got them, at the cruising altitude dose that you have selected for them, let's say it's 50 milligrams or 100 milligrams. If they're responding and they're happy and they're sleeping well, then that's something you would probably be inclined to continue doing. If you get to 50 milligrams and they're doing okay, and you take them to 100 milligrams and then they can't sleep and then they're tired the next day, and then they start going downhill clinically, then obviously you would know, based on your experience with that particular patient, that 50 is a good dose and 100 is too much. Again, I personally would never imagine going to 500 milligrams. I also think that I wouldn't need to, because most of the time I would be doing other things that would be synergistic with this. And, instead of putting all of my eggs in one therapeutic basket, I would be looking at getting benefits from other interventions. So again, it depends on what you're treating. But if you're treating inflammatory disease, you could use, like I said before, you could use a little bit of pregnenolone, maybe a little bit of DHEA, an aromatase inhibitor, plus or minus direct, testosterone replacement if that's appropriate for that particular disease and that particular patient. But you've got other interventions that you could do along with that, independent of this steroid hormone pathway. You could look at thyroid hormone, of course. You could lower prolactin levels, etc. So you've got a lot of, in the anti-inflammatory world, we have a lot of interventions that we can use, so we don't have to use, super physiologic doses of any monotherapy, whether it's a drug or a nutrient or a hormone. We have a lot of options, and using a synergistic plan is, in my opinion, what makes our plans successful. So that's my kind of video introduction to this topic on pregnenolone, which I haven't touched on in years. But again, if you look at the information in Inflammation Mastery, I don't see any need to change that. I can always embellish it. I can always add more studies. But the studies that I have seen previously, and the ones that I've seen over the last couple of years, when I touch on this topic every now and again, I don't see any need to change that. And this is another example. If I put this information in the book, let's say, and say they started at 100, then they went to 300, then they went to 500, I would have to, as I've done in this video, provide my personal and clinical experience with that, and that is to say I would never go that high. But the benefit of looking at clinical studies like this is that it provides us reassurance that we could go that high, and if 500 is safe, then certainly 50 or 100 would be expected to be safe. And for example, if you ever have to defend what you're doing clinically, like for example, like when I first started practicing, I practiced for a year in Seattle because I was living in Seattle at the time, and then I moved back to where I had grown up, which was Houston, Texas. But basically, I was doing naturopathic medicine under my chiropractic license when I moved back to Texas. This was before, of course, I went to medical school. So the problem with that is that the Texas Medical Association is very, very aggressive, and they hate chiropractors. So I knew that if I was going to do like whole patient integrative medicine, kind of naturopathic medicine, but under my chiropractic license, I had to be very clear and very safe with regard to my interventions and my documentation. So basically, for the 6 years that I practiced in Texas before I went to medical school, when I was doing, integrative medicine and naturopathic medicine and functional medicine under my chiropractic license, I got in the habit, and that's, that's when I was writing books and doing a lot of research, a lot of literature review research. I got in the habit of being very clear on risk-benefit ratios and making reasonable clinical decisions because I knew that who knows when, but at some point I was expecting that, the Texas Medical Association could send me a decoy patient to kind of trap me, which is what they commonly did with so-called CAM providers. So I knew that they could send me a decoy patient and I would have to defend myself then based on what I had done. So, when they do medical witch hunts like that, they're going to reach whatever conclusion they want, and they're going to, try to dole out whatever punishment they want. So it's not like being a good doctor defends you from, medical persecution, but at least I would have the references and the resources to try to defend myself. So again, like I said, when I started practicing in Texas, I started my practice knowing that I had to practice very defensively and be really clear on justifying my interventions. And I think I've walked you through that line of thought in this conversation. So I'll let that bring this video to a close. Hope you're all doing well. I'll get some more videos on the website as soon as I can. Again, take care. Hope you're all doing well. And this has been Dr. Vasquez from healthythinking.substack.com and inflammationmastery.com, and the other clinically oriented site, which is inflammationmastery.substack.com. So the difference between those two Substack blogs or websites is that in Healthy Thinking, I basically talk about anything and everything I want. At the other one, Inflammation Mastery, I try to keep it a little tighter to clinical topics. But everything that I would ever post there has already been posted at Healthy Thinking. So for those of you who love my social commentary, you get everything, including architecture and logic and philosophy and psychology. I put all of that at Healthy Thinking. Again, at the Inflammation Mastery site, I try to just keep it clinical and try to keep my social and political and personal perspectives at least a little bit filtered and limited. So again, I hope you're all doing well. I'll get this on the website as soon as possible. Take care. Bye.
Adieu Lisbonne, vieille cité du Portugal, sous ton ciel bleu sans égal, tu apparais royal. Lisbonne, les mille feux de ton port semblent danser sur des guitares d'or le soir quand tout s'endort. En évoquant mon enfance, j'entends encore les romances, les rimes léchées du fado, des guitares et des danses.